Thank you, Dr. Usama. My dear colleagues, I've been asked to present only one case for the sake of saving time. So this is a case of keratoconus in 31 years old female. Uncorrected distance visual acuity 0.2, the best corrected 0.4 with only minus 1.5 and minus 1.75 cylinder. She has night vision problems while driving and the deterioration of vision for the past 6 months, contact lens intolerance, working in airport customs, so she has to drive at nights to cover her shifts. So these are her images in the pentacams, and in the lower right we can see the difference in the epithelial map between her right eye and her left eye. We can see the thinning in the epithelial layer. Here we can tell that the thinnest part of the epithelium, which is 36 microns over the steepest part of the cornea, and the thinnest part of the epithelium, which is the thickest part of the epithelium, which is 55 microns, over the flattest part of the cornea. So our technique that we use, we call it MITEX, minimally invasive topography, customized cross-linking. We take 8 pentacam images, good epithelial map. We plan for an optical zone of 6 or 6.5. The topographic astigmatism axis derived from the pentacam, and we play with the magnitude of the astigmatism and the sphere to achieve hyperopic portion of the treatment, ablating only 10 to 15 microns. Here we see in the treatment details that the measured was minus 1.25, but we did not include this in our treatment. Only part of the astigmatism to save the tissue and to be able to do an optical zone of 6.5, ablation zone 9 millimeter. Here we can see the treatment plan, that in the apex of the cone we are going to ablate 45 microns from the stroma. And here, we subtract the epithelial thickness from the ablation profile. This is the ablation in the stroma, while in the periphery, we will remove about 15 microns. But in the center of the cornea, we are not going to touch the Bowman's membrane, even leaving it covered with 15 microns of epithelium. Where the procedure is a straightforward topo-guided treatment, and then we do a cross-linking accelerated for 10 minutes. We can debride the remaining epithelium if you want to hasten the healing better, or we can leave it. Then the routine post-operative steroids and antibiotics. This is a surgeon's view from the microscope while doing the treatment. This is immediately after the epi-on topo-guided PRK during the cross-linking, after debridement, and the topo-guided PRK profile from the surgeon's view. And here, when we look at it, we'll see that the epithelium is still intact, partially or fully, except in the areas of the stromal ablation. We have flat area next to the cone did not receive laser, no more flattening. Same area received less dose of cross-linking. Less flattening, the cone myopic ablation received the stromal ablation. Flattening the peripheral hyperopic ablation zone received the stromal ablation. That gives us more flattening. Can I have that? Oh. Same two areas received the full dose of cross-linking. So when you receive the full dose of cross-linking, you have more flattening than the area adjacent to the apex of the cone, less flattening because it is still covered by 15 microns of epithelium. Combining all this will give coupling effect that will lead to more corneal regularization, as we see here. Now we see islands of ablation in a sea of Bowman's membrane. We did not remove all the Bowman's membrane. This gives better biomechanics, less haze in those areas. The ablation pattern creates a gradual lake-like depression rather than a sharply defined edges due to the transition zone. We can see here in the OCT two demarcation line from the cross-linking, because areas had epithelium, areas did not have epithelium. When we look here at 5 years post-op, the uncorrected distance was 0.2. The best corrected was 1 with minus 2.25. Night vision is much better. Here we can see that we achieved 3.8 diopters of steepening in the flat area and almost 9 diopters of flattening in the steep area. This gives us a total of 13, almost 13 diopters of regularization of the cornea using an optical zone of 6.5 only by removing 22 microns from the center stroma when we compare the epithelial maps before and after. Thank you. This is how it looks. The cornea is crystal clear.
Thank you very much.
Thank you.
So what is the type of the machine that's used for this?
The wave light, EX500.
The wave light. And you don't have in the front, that's the area which is the intact epithelium, which is not crossed, to be progressed later on.
No, there is some effect of cross-linking, but not the full effect like the areas with removed epithelium. That's why we have seen two demarcation lines of cross-linking. And this is a follow-up for 5 years now. That's why I presented this case. We have, with this kind of follow-up, like 30 cases so far. They are all stable and doing very well, actually.
Okay, thank you.
This is the idea behind the customized cross-linking, not to do the equal amount of cross-linking all over the cornea, because you will keep the irregularity. When you do this, still you will have more steep areas and more flat areas like before the cross-linking. But here we try to regularize the cornea by flattening the steeper and trying to elevate the periphery of the cornea to regularize the surface.
Yeah, it's a very interesting concept, combine topography to improve and cross-linking more, so it is very interesting.
Would there be any difference if the patient was like 13 years old, like you have more chance of progression, you would still choose to do the wavefront guided cross-linking or a regular one because it may progress further?
No, because, cross-linking only stabilizes the case. In patients with reduced vision, with visual symptoms and complaints, we aim to regularize the cornea to improve the corrected distance visual acuity. With cross-linking alone, you cannot improve the vision. You hopefully maintain it. But with this, you improve the vision, and we have seen here it improved the corrected distance from 0.4 to 1.
Any question from the audience?
Thank you, Dr. Hani, for this nice technique. What's your minimum thickness you can work with your technique?
With the epithelium 400.
With the epithelium 400,
but
you don't have go for thinner cornea.
I have other patients that can that shows us that sometimes we are surprised that the corneal thickness after the ablation, after the remodeling of the epithelium, the corneal thickness after the treatment is thicker by 10 microns, for example. So we save the tissue, and even we have more tissue than before, because the thinnest areas in the epithelium, which could be maybe 35 microns, 40 microns, they recover the 50 microns of thickness after regularization of the cornea.
Apart from your technique, do you do cross-linking for thinner cornea than 400?
With the hypotonic, yeah.
Yeah, yes. Thank you.
Thank you.
We did very well with the timing, so especially one speaker less. But if any question for any of the speaker, please. Yeah.
Actually, the technique that Dr. Hani have done is very interesting because there is a partial ablation of the bone membrane, Dr. Hani. And I think this has its point. The door. The partial ablation. Bone membrane once cut never heals except by fibrous tissue. But partial ablation with high-speed lasers that we have today, probably it added to the cross-linking effect. What do you think?
PRK tissue, you know that the type of collagen that laid after PRK is stronger and tougher than the normal collagen. Here we also have a series of only topo-guided cross-linking without touching the Bowman's. And but it depends on the case, of course, and how much regularization you are aiming for. To remove only epithelium, the apex and at the periphery, topo-guided removal of the epithelium without, with keeping the Bowman's as it is, without stromal ablation. Yeah. You know, Bowman's is 15 microns, from 8 to 15 microns, so you can still within the Bowman's in many cases, but in some patients, you might need to remove part of the stroma. Stromal ablation, but much less than what we used to do before with the combined technique of topography-guided PRK with cross-linking.
I mean, partially ablating the Bowman membrane might be a new addition to the cornea as a cross.
I will tell you what. You know that it depends on the corrected distance visual acuity. Dr. Demian Gatinel in Rothschild in Paris, he never practiced cross-linking. He only do PRK for patients with keratoconus. Only PRK. But if this PRK is going to give them good vision in early patients, of course, because it depends on your theory and in your concept. In your concept that removing part of the stroma is going to make the corneal tissue tougher. So he does not believe in cross-linking. He believes only in changing the nature of the collagen in the cornea. Very strange concept, but it is still, he has published many. Dr. Osama knows him very well, and he can give us take on this.
Regarding the mitomycin C, he didn't use mitomycin C.
No. We never use mitomycin C with cross-linking because it produces a very dense and deep haze. Yeah. Yeah.
Last question. Thank you very much, everyone. And to conclude for the session, it's a pleasure to have you all.
There is a group photo for all the delegate and the speakers at the beside in front of the registration desk. All the delegate and speaker, one huge group photo. At 1 o'clock, then the prayer, Jum'ah prayer, will be. It is organized just in front of the window. There is a red carpet, and all the people are going to pray in the same area.